Good morning, everybody. This is Andrea Rasser at IAMS, here this morning to chat with you on underwriting mental health disorders. I'd like to thank everybody for being here. Obviously, this is a subject we see every single day. Honestly, there's a lot of impairments that we see daily or weekly, but this is one I see multiple times per day. So I thought it would be a good one to cover, and should probably say up front, there's going to be some touchy territory here. Probably should have put out a trigger warning. There's some deep topics that are going to come up. But like I said, we do see these every single day, multiple times a day, oftentimes. And so we can't shy away from that. So with that, we're just going to get right started. What we have found in society today is that we have millions and millions of people that are affected by mental illnesses every single year. Globally, people just like you and I, we're working, we're performing, we're creating, we're competing, laughing, loving, inspiring, doing all those things every single day. And yet, this mental illness is still there and people are not necessarily aware of it. It's very well hidden. Diagnosing these mental illnesses is not a very straightforward science. We can't test for this the same way that we test like for diabetes. We can look at blood sugar levels. With cardiac ailments, we can go look at an EKG. Mental health isn't like that. And each condition has its own set of unique symptoms. And where things get really complicated is that a lot of times these symptoms overlap. So it can be very, very difficult for doctors and underwriters to diagnose and tell what's going on. So that's why having the constant doctor's visits are important, because obviously underwriters aren't diagnosing anything, they're just reviewing. So if we look at the prevalence in the United States today, what we have seen is that 1 in 5 adults will experience a mental illness annually. When we say mental illness, this is going to be more the minor anxiety, depression type mental illnesses. We increase that to a more severe ailment such as bipolar, schizophrenia, something like that. And it's actually 1 in 20 adults that will experience a serious mental illness. So lower numbers as far as who's experiencing it, but those are the more severe side of things. And then what's also interesting and somewhat concerning is that 1 in 6 of our youth, youth being age 6 to 17, also experience a mental health disorder each year. 1 in 6 is kind of scary, considering that's only one less than the adults are experiencing. So, when your kid comes home from school and they've had a rough day, I wouldn't blow those off. That can be very, very real, and it is very real for them, and it can be signs of something ongoing. What they have found is that 50% of all lifetime mental illnesses actually begin by age 14. So seeing these symptoms in today's youth is definitely not something to be ignored. They've also found that 75% of these are diagnosed by age 24. So a lot of times these are being found in our younger generations and diagnosed earlier. When we start looking at the prevalence, not necessarily by people, but by condition, what we are finding is that anxiety is number one. It comes in at over 19%. I think we all have suffered some anxiety in our lives, and so that makes a lot of sense. Coming in number 2 is going to be our major depressive episodes, just over 8%. Bipolar, we see a bit of a drop, and it's just over 2%, under 3%. PTSD has become a little bit more common, right under 4%. OCD at 1.2. Schizophrenia is a little bit lower. That one's going to be considered more severe. But these are the most common disorders that we're seeing. Some of them that I don't have listed here, some of the eating disorders, anorexia, bulimia, things of this nature. Those do also fall under mental health. I just don't have them noted here because they weren't the more common ones. And now if we break down the prevalence by demographic groups, what we have found is that in our non-Hispanic, mixed, multiracial individuals, the prevalence is right about 35%. When we get into the LGBTQ community, it increases up to about 50%. The American Indian, Alaska Native community, we're looking at around 26%. If we get into non-Hispanic whites, it's not much lower. It's at 24%. So it is prevalent among all demographics. Nobody is immune to it. So just one of those things that to keep in mind as you're meeting with clients, that no one is free from mental illness. This affects everybody. So why does this really matter in underwriting? There's a lot of ripple effects when it comes to mental illness. There's a lot of things beyond that mental illness that can affect the person, the community, and the globe, the whole entire globe. When it comes to the personal effects of mental illness, what we are finding is that people with depression have a 40% higher risk of developing cardiovascular and metabolic diseases, more so than the general population. If we look at people with serious mental illnesses, again, like the schizophrenia, psychosis type stuff, they're nearly twice as likely to develop these conditions. So it doesn't just stop with a mental health disorder, it overflows into other aspects of their life. 34% of adults with mental illnesses also experience a substance use disorder in conjunction with this. So that is something that underwriters look at very, very closely when they're underwriting mental illnesses. They do look at any kind of alcohol or drug use. The rate of unemployment is much higher among U.S. adults who have a mental illness. It's 7.4%, which compared to those who do not have a disorder is about 4.6%. So that almost doubles. High school students, once again, the youth of the nation, when they're faced with significant symptoms of depression, they're more than twice as likely to drop out of high school. Additionally, students with mental, emotional, behavioral concerns are 3 times more likely to have to repeat a grade. So again, it's not just a mental illness and it stops there. It affects every aspect of their lives. Now, if we take this a step further and we look at how mental illness affects our communities today, what we will find is that 21% of people that experience homelessness in the US have a serious mental health condition. Now, I personally have to believe that number is actually higher because not everybody has actually gotten the proper diagnosis. If we had proper diagnosis for every homeless person that we see, chances are that number would increase. Among people in the US that are under age 18, depressive disorders are the most common cause of hospitalization. Now, this excludes childbirth, so forget about that. But under 18, depressive disorders cause the most hospitalizations. If we look at the age 18 to 44, in the psychosis spectrum and mood disorders account for nearly 600,000 hospitalizations each year. We have found that almost 20% of US military vets experience some kind of mental illness, and almost 10% of active duty service members are experiencing some kind of mental health or substance use disorder. Across the US economy in total, we've found that serious mental health illnesses cause about $193 billion in lost earnings every single year. So that's where it falls into the community. You know, it doesn't just stop at home. This affects a lot of things in everybody's daily lives. And if we go one step even further than that and look at how this is affecting the global community, we have found that depression and anxiety disorders cost the global economy over $1 trillion in productivity every single year. We have also found that depression is the leading cause of disability worldwide. Um, some may think that, it's disability, they think physical, and that is definitely not the case. Depression is the leading cause of disability. All right, so we're going to take a step back and talk about COVID and mental health. I know you may be wondering why I want to go back in time and talk about COVID, because we're kind of almost sort of past that. But the truth is we're not when it comes to mental health. And I say that because the cases we're underwriting today are highly affected by how people reacted and adapted during COVID. And those youth that we were talking about, the ones that we're going to be insuring here in the future, maybe presently, they were highly affected by this as well. And it has had a major, major impact on mental health and underwriting. So 2020, it was a year of challenges. Obviously, there was a lot of things going on. It was marked by a lot of loss, a lot of uncertainty. The youth and the young adults, especially, they experienced a unique set of challenges during COVID. They were isolated from their peers. They were adapting to virtual learning. They had a lot of changes in their sleep habits and their other routines. And we just have to recognize the significant impact that pandemic had on our mental health, um, and the importance of increasing access to timely and effective care for those who needed it, because that was one of the biggest problems too, is that people were not able to access the care that they needed. So what we found is that 1 in 15 adults experienced both a substance use disorder and a mental illness combined. It wasn't one or the other, it was both. There were over 12 million US adults that had serious thoughts of suicide. I don't know what the number was for the children, but that's a pretty high number for adults. 1 in 5 adults reported that the pandemic did have a significant negative impact on their mental health. Whether or not they sought treatment is another story, but 1 in 5 reported it was an issue. For our adolescents, we had 1 in 6 that experienced major depressive episodes, not just a bad day, but major depressive episodes. Among the US adults age 18 to 25, 1 in 3 experienced a mental health illness. And among people over age 12 who drank, I know over age 12 seems low, but they do drink too sometimes, 15% reported an increase in drinking. And for those who use drugs, 10% reported an increase in drug use. And I don't think a lot of that's very surprising. I think during COVID, we saw a lot of people that just decided they could day drink. They could totally change their sleep patterns and, get on a webinar and have wine with the coworkers. It was kind of a way to get people back together, but it also encouraged a lot of willy-nilly drinking when they might not have under other circumstances. All right, so I'm going to talk about some of the more commonly seen disorders in underwriting, because mental health, obviously, that covers a lot of topics. It's a very broad category. The number one ailment that we saw was anxiety. I think we already kind of mentioned that, but everyone can experience anxiety. That's a day-to-day thing. And you could be anxious about getting ready to go perform or turning in a paper that's due. But when these symptoms become overwhelming and constant and it starts impacting everyday life, that's when it may be considered an anxiety disorder. The second one we see is depression. Depression is going to involve recurrent severe periods of clear-cut changes in your mood. Having a bad day doesn't necessarily mean you have a depressive disorder. The thought process and the motivation or lack of motivation lasting for a minimum of 2 weeks that's when they really start to question whether or not it's a disorder versus a situational thing. Changes in your thought process, typically including negative thoughts, hopelessness, um, involvement that, your energy and your sleep level are down, your appetite changes, significant weight gain or weight loss. All of these long lasting can be signs of depression. When we jump a little bit more severe beyond the anxiety and depression that we see most commonly, then we start to get into things like bipolar disorder, personality disorders, and PTSD. Now, with bipolar disorder, you're going to see dramatic shifts in a person's mood, their energy levels, and their ability to think clearly. Individuals with this disorder usually experience very extreme highs and then very extreme lows, known as mania or depression. Some people can go symptom free for many, many years between episodes, and many people, especially with bipolar, can be symptom free for years with the correct medication and dosage and compliance. Compliance there being key. One thing we never want to see is somebody just stop their meds because they feel better. Well, you might have felt better because of the meds and maybe should stay on those. So that's one that we see pretty often. The other being borderline personality disorder, a lot like bipolar. It's a pattern of instability in emotions. It definitely can affect interpersonal relationships, self-image. A lot of times individuals with borderline personality will struggle with impulses and self-harm. And then one that I think we're all pretty familiar with is going to be PTSD. Now, this involves a set of physiological and psychological responses. This typically occurs in people who've experienced or witnessed a traumatic event, such as a natural disaster, a serious accident, an act of terrorism, assault, war, combat, anything similar to that. We see PTSD oftentimes in the movies, but we see it oftentimes in underwriting as well. Once we get beyond some of those more basic disorders, we've got some more severe levels, and get into things like schizophrenia and psychosis. With schizophrenia, this is going to interfere with a person's ability to think clearly. They can't manage their emotions. They make decisions that make no sense. It can cause people to lose touch with reality, oftentimes in forms of hallucinations or delusions. It is highly treatable with the appropriate medications, and sometimes even insurable. When we get into psychosis, this is a disruption to a person's thoughts and perceptions that make it difficult for them to recognize what is real and what is not. While there are medications and it is treatable, it's not typically insurable, but never say never. Never say never. It could happen at some point with the right treatments. So one of the biggest issues we run into when it comes to mental health disorders is diagnosing them. Like I said, there's not any clear-cut test out there like diabetes and blood sugar levels that will tell us this. So it does require a lot of work on the doctor's part and the patient's part to get the appropriate diagnosis. And some of the tools that are most commonly used and that we look for in medical records are going to be the Global Assessment of Functioning, otherwise known as the GAF. This can be found in most medical records, whether you have a diagnosis or not. Sometimes doctors will just give you these tests just to make sure that you're doing okay. The Global Assessment of Functioning is basically a scale, and it's used to rate how serious a mental illness is. So a lot of times doctors will use this after a diagnosis. This measures how much a person's symptoms affect their day-to-day life on a scale of 0 to 100. It was designed to help mental health providers understand how well a person can do their everyday activities, what level of care someone may need, and how well certain treatments are working. So we may see this test 5 or 6 times in a person's medical records because the doctor gives it to them every time they visit, because they want to see if that medication is actually doing what it's meant to do, or if they need to increase the dosage, decrease the dosage, completely change the medication. Maybe it's not working at all for them. On this score, on this test, the higher you score, the better you are able to handle your day-to-day activities. The other test that we see most commonly in medical records is the PHQ-9, otherwise known as the Patient Health Questionnaire. This one is self-administered. It's something that the client does on their own. It's a screening tool to assess the severity of depressive symptoms. This one's used most oftentimes with depression. This questionnaire basically assesses how often the subject has been disturbed by any of these 9 particular items in the immediately preceding 2 weeks. So basically, it'll have a question like loss of interest in things that you normally have fun with. And you put 0 to 3, 0 being not at all, 1 means several of the days, 2 is more than a week. And if they put 3, then that means they're having symptoms nearly every day. So the PHQ scores range from 0 to 27. And basically, if you have a lower score, you're going to be classified as mild. Mid score, you got your moderate, and then the more points you have on that, the more severe the depression, basically. So the PHQ is going to focus in on how severe depression is. The GAF is going to focus on how well your treatment is working, regardless of what mental illness we may be looking at. Now, when we look at treatments, what we have found is that psychiatrists, they're going to use a variety of different treatments. There are various forms of talk therapy, medications, psychosocial interventions, CBT, otherwise known as cognitive behavioral therapy, ECT, electroconvulsive therapy, and it all just depends on the needs of the patient. These psychiatric medications typically influence brain chemicals that regulate emotions and thought patterns. They're usually more effective when they're combined with psychotherapy. In some cases, medicines can reduce the symptoms so that other methods of treatments can be more effective. So, for example, a medication can ease your symptoms of depression, like the loss of energy, the lack of concentration, and that will allow the individual to engage more in talk therapy. So they definitely coincide and work together there. In some cases, psychiatric medications may be short-term. They may only be taken for a few months. This is something that we see a lot of times with the loss of a loved one. You'll see that someone has lost a family member and their doctor instantly prescribes them Xanax because it will help them get through those next few weeks or days. In other situations, the medications may be long-term. They may even be lifelong. As an example, we go back to bipolar. That is one where we oftentimes see that it is a lifelong treatment that is required. It's not something that you can just start and stop medications depending on how you're feeling any given day. A lot of these treatments usually consist of pills that are taken daily. Some are liquids, some are actually injections or patches or dissolvable tablets. People who have difficulty remembering to take their medications will sometimes opt to do a shot at the doctor's office that's, once or twice a month. Maybe that is easier for them than remembering to take pills. But predicting who's going to respond to what medication is incredibly difficult because different medications may work better for one person than they do for another. Doctors will usually review clinical records to see if there's any evidence that exists for recommending one medicine over another. They will also look at family history and side effects when prescribing those medications. And they'll go back and they'll do that GAF test to find out if it's working and if they need to make any changes. Some of these psychiatric medications will work very quickly. Again, the example I'll use there is Xanax, very fast acting, kind of calm a person down when their anxiety levels are really high. And so with some of these meds, you may be able to see improvements within days and sometimes even hours. But most of them for true long-term disorders are going to work more slowly. They may take several weeks or even months before somebody sees complete improvement or satisfactory improvement. Providers will typically start at a very low dose, and they'll slowly increase those dosages until they achieve a level that really improves those symptoms. The key here is finding the medication or the combination of medications. Oftentimes there's more than one that works best. If a medication isn't working or causes side effects, we do not want to see patients just stopping their medication because they don't like it, or it's just they don't think it's working. It's really important they consult with their providers to discuss any adjustments or to taper off of those appropriately. Many people won't have any side effects, or they'll go away within a few weeks. But if they continue, changing medications or the dosage will oftentimes help. Again, we don't want to see people stop cold turkey. A lot of times discontinuing these treatments without tapering off appropriately can cause a lot of side effects that are worse than the drug itself. So that's something they really want to work with their doctor on. And that just allows the brain's chemicals to adjust slowly to the change. It can be very uncomfortable if those are just stopped. The side effects can be very, and they leave people bedridden even. All right. Some of the most common medications that we see are going to be antidepressants. They're used to treat depression, anxiety, and sometimes other conditions. So again, we will see crossover. One medication may be an anxiety med for one patient and a depression med for the next. A lot of times with antidepressants, these improve symptoms such as sadness, hopelessness, lack of energy, difficulty concentrating, lack of interest in activities. These are not typically addictive and don't typically cause any kind of dependency, typically. When we move on to the anti-anxiety medications, these used for anxiety disorders and some panic disorders, they can help reduce agitation and insomnia. And a lot of long-term anti-anxiety drugs are actually antidepressants, and they just happen to work for anxiety. Fast-acting anxiety drugs that help with the short-term relief, again, like Xanax, those have the potential to cause dependency. So ideally, they only want to see those used short-term. Then we move on to a little bit more severe into the mood stabilizing medications. These are most commonly used to treat like bipolar disorders. And these are oftentimes used in conjunction with antidepressants to treat depression. So we see those used side by side very often. And then there are antipsychotic medications out there, and those are typically used to treat your psychotic disorders such as schizophrenia. These can also be used to treat bipolar though, and are often used in conjunction with an antidepressant. So it's important when we're shopping these out or looking at medical records or reviewing an application to know exactly what the client's diagnosis is, because in looking at their drugs and their prescriptions and what they've been given, we don't know what they're being treated for. There is so much crossover in all these medications that it's imperative we get the actual diagnosis that's been given by the doctor. There's a lot of times that we'll see somebody's quick quote come in and, the guy has a little depression is what the agent says. Well, it actually turns out, that he's been diagnosed bipolar and PTSD. Depression was never even part of the diagnosis. They just assumed that based on the meds. So it's just with that crossover, it's just important that we know exactly what they've been diagnosed with. So going back to kind of COVID-19 and the things that we've seen in the last 5 years have been major barriers to treatment. Access to treatment is it's very limited. There's a shortage out there of professionals that can help with these disorders. And what we have found is that the average delay between the onset of a mental illness and treatment is actually 11 years. So if you think about those 14-year-olds who are living with some kind of disorder, a lot of them aren't even being diagnosed until they're in their mid-20s. Some of the issues we've run into is our clients in rural areas. In the non-metropolitan areas, we have found that only 48% of those with a mental illness are actually receiving treatment. And those with serious mental illnesses like schizophrenia and such, only 62% are actually receiving treatment. So that leaves 40% out there that are untreated. If we compare suburban and urban residents, rural America, they have to travel twice as far to get to their nearest hospital if there's a problem. And they're 2 times as likely to lack the broadband internet, so they don't have access to the telehealth like some of the people in the city. These are obvious concerns. And for those that are receiving mental health services, what we found in the past few years, there were over 17 million adults who were trying to obtain care, but experienced delays in care, they canceled appointments. Many people were unable to get the prescriptions that they needed because of a shortage. Over 5 million were unable to access the care they needed at all. And then one of the more striking numbers here is that the hospital saw a 31% increase in mental health related emergency department visits. So again, the pandemic, the lack of access to care, it had a huge impact on society and the hospitals and the way these things were being addressed. So with all that now said, let's get into some underwriting and how this all plays out from an underwriter's perspective. So some of the things we're going to need, we are absolutely going to need paramed and labs. Definitely going to need to see medical records. They're going to want to see details of all the treatment, any serious complications, any hospitalizations. They're going to want to look at a prescription history. A lot of times they'll run the prescription background report that gives the underwriter a very at a glance look as to whether or not the patient is compliant with all of their medications. They're also going to look at medical claims history. And then drug and alcohol use. That is something that is obviously going to be asked on the application or the Part 2. But sometimes the carriers will ask for a drug and alcohol use questionnaire, even if there's no obvious reason. It's still something that they really watch in conjunction with mental health disorders. And so you should never be surprised, I guess, if that becomes something they ask for. It doesn't mean they saw anything that stood out. It just means they're ruling it out. And in reviewing all of this, what they're really looking for is evidence of stability for a minimum of 2 years of the mental health disorder and verification of employment, or if it's a student, that they're still going to school, that kind of thing, and that they're still functioning well in society and compliant with their treatment. That's key right there. So if we look at the outcomes that we most commonly see based on severity, there is minimal depressive disorder or situational anxiety and such. This falls under the category of there's been no diagnosis of depression. you have very infrequent symptoms, that GAF score is over 80, so it's between that 80 to 100 range. There's no regular counseling required or recommended, no medications. You're otherwise meeting the criteria of a mild depression symptom. No hospitalizations, no suicidal ideations, no special therapies. We can absolutely see preferred, sometimes even preferred plus on these. Again, everybody has bad days. Everybody gets anxious sometimes. That doesn't mean it's a disorder. So those we can typically see preferred or preferred plus. When we bump this up to what would be considered a mild disorder, this is going to be a depressed mood that causes sufficient distress as to be noticed by others. It's enough that you seek counseling or treatment from a doctor. It doesn't necessarily disrupt your relationships, your social functioning, or your work life, but it's enough that you're concerned about it. You talk to your doctor. Your GAF score is somewhere between 70, 80. No suicidal thoughts, no history of hospitalizations. You're not having the chronic sleep disturbances or the weight changes. These symptoms are easily controlled without medication or a very low dose of one medication. The doctor may not want to see you again until your next annual physical. They don't need to see you constantly. They just say to call if anything changes. No history of substance abuse is going to be looked at. This will be considered mild, and usually in this situation, we can see standard to preferred. That one is probably the one we see the most often, I would say. And then next being our moderate disorder. Now with the moderate disorder, it's going to be a little bit more severe, resulting in greater impairments on the relationship, little bit greater impairment on the social functioning, school functioning, employment. Might see somebody who's calling into work constantly. They're still holding their job, but it's becoming an issue. That GAF score falls somewhere in the 50 to 60 range. Their doctor wants to see them more often. They want to see them every 3 to 6 months. Their need for medication is probably going to be a higher dose, usually 2 or more antidepressants. It can oftentimes be associated with chronic PTSD. Oftentimes there is suicidal ideation, but without a plan, and that part is key. It's without a plan. Oftentimes, again, there are multiple medications or higher doses there. If there's no history of hospitalization, anything like that, this is going to fall under moderate. And when we look at moderate depressive disorders, we're usually looking at about a table 2 and up. This is where it gets a little bit harder to stay in that standard range. And then if we take it a step further to severe depression, this is going to be where we have serious impairments in our relationships, and in our social functioning, school functioning, employment. That GAF score is much lower, down in the 40 to 50 range. Multiple medications are in use. Oftentimes, an antipsychotic could be in use. Sometimes we'll see severe functional impairment, such as disability from work, impaired judgment and communication, hospitalizations. These we're usually going to see a decline for about 5 years. Now, occasionally, after review by a medical director, if they see all the right things are being done to treat this and there is compliance and stability, sometimes we can get these in less than 5 years, but it's typically about 5 years before anyone in this situation is going to be able to obtain coverage after control is in place. And now if we get into the super severe, below 40 on that GAF, again, suicidal ideation or attempts, severe vegetative symptoms, extreme weight loss, insomnia, sufficient enough to impair your daily functioning, and psychotic features, these will absolutely be a decline, unfortunately. Some things to keep in mind, because we do see this quite often, are going to be suicidal ideations and attempts. What we do know is that suicide is the second leading cause of death among young people aged 10 to 14. It is the third leading cause of death for those 15 to 24. So that is something they look at very closely when looking at mental health disorders. We have also found that suicide is the 12th leading cause of death overall in the United States, and 46% of people who die by suicide have been diagnosed with a mental health condition. 90% of people who die by suicide may not have been diagnosed, but they have experienced symptoms of a mental health condition. And so that is something, that is one of the reasons they ask about suicidal thoughts on the application. Something just of interest to some may be that 79% of people who die by suicide are actually male. So we do look at the male population a little bit different than the female population when it comes to how well the symptoms are being treated and if they're being addressed and if there is compliance there. What we typically see from an underwriting perspective is that a single suicide attempt within the last 0 to 2 years, we're going to see a postpone. That's probably not going to be touched for at least 24, 48 months. If it's been greater than 2 to 5 years, and everything is now well controlled, there's treatment, there's compliance, there's no suspicion of alcohol or drug abuse, typically we'll see about a table 4 with a flat extra. They do put that flat extra on there usually for about 5 years. Now, this is not all carriers. This is kind of broad-based, but once we get past the 5 years and we're in that 5 to 10-year range, then we usually start seeing just the 4 tables, no more flat extra. And once we get past 10 years from that attempt, standard typically can be available. More than 2 attempts, we're probably going to see a decline for a minimum of 10 years. If there is a history of schizophrenia or bipolar disorder in conjunction with the suicide attempts, again, we're going to see that declined probably for 5 to 10 years. And if there's any suspicion of alcohol or drug abuse, it will be a decline as long as drug or alcohol use is still in place. Even if it's no longer seen as abuse, but just use, it's still going to be a decline. They want to see that completely stopped, basically. So before I get into how IAMS can help, I've got a couple cases I wanted to go over. I'm sorry I don't have slides for them, but I found them to be very interesting and thought I'd share these wins with you. So first, we had a female. She was in her 40s. Back in the 2010 timeframe, her husband was killed very unexpectedly. Life kind of spiraled out of control. She was suffering from PTSD, depression, anxiety. All of these things became a major issue. She began self-medicating with alcohol. Over time, she recognized this was not healthy. This is not who she wanted to be. This was not how her life was supposed to go. So she started seeing a therapist. She was admitted to the hospital. Her therapist started her on some medications and diagnosed her as bipolar. And when she went into the hospital, she wasn't necessarily suicidal. She just no longer had a desire to live. So she continued with her therapy. They determined she actually was not bipolar. That was a bad diagnosis by her doctor. That was very inaccurate. All of this was situational. We had to get records from her current doctor confirming and stating unequivocally she was not bipolar. This was situational. She is no longer on medications. She hasn't been for about 5 or 6 years. She's also not had a drink in the last 5 or 6 years. She is very successful in her business and has come out on the other side okay. So we sent quick quotes out,
And what we got back were 5 declines, which really didn't surprise me with the hospitalization. We also had another 5 or 6 carriers that came back and said, well, we'll look at it. We got to see the records. This is all very subjective, and we're probably looking at like table 2 to 6. It's like, okay, all right, that's not bad. But then we had 4 carriers that came in at standard. And the big difference in the reason they came back standard, was because they looked at this very holistically. If I just sent them the facts and said, these are the drugs, these are the dates, they would have said this is a decline. But we told them a story. We showed the progression of the disease, her way out of it, the fact that it was situational, and they were able to take a holistic approach and see her as the human she was, and we got her standard. The next one I have, we've got a gentleman about 60 years old, retired Navy officer. He is on 100% disability with the Navy. That in itself can be a little bit tricky. He had a traumatic brain injury back in his 20s. It wasn't bad enough to get him out of the military because he stayed in the military for 20 plus years and just retired a few years ago. So the brain injury wasn't as big of an issue as I originally thought it was going to be. But he also had PTSD, and that was from an attack at the naval station in Pensacola. He was unfortunately involved in that. Additionally, he was getting ready to retire, and that came with a lot of extra anxiety and stress, a lot of PTSD, a little depression, and so he had a lot going on. But he was doing better. He was not experiencing any symptoms. He was taking all of his meds completely compliantly. Um, and so we went ahead and shopped this one out, and we ended up getting 5 declines. We had a lot of people that just wouldn't even look at it. We had multiple offers in the 2 to 4 range. We had 1 carrier who offered standard. It was, of course, subject to no hospitalizations, no suicide attempts, no missed work, no substance abuse issues, but he was able to get standard, even with that PTSD, depression, and anxiety all noted, and multiple medications also. And last but not least, we have a young man in his 30s. This one was interesting because he uses medical marijuana. Now, a lot of times when we're dealing with depression, anxiety, PTSD, any of these mental health disorders, they do not want to see any kind of drug use. Not just abuse, but use. They want no alcohol or drug use issues there. Marijuana being one of the bigger ones. But this young man, it was medical marijuana. It was being prescribed in Arkansas with a marijuana card. He also had some back pain issues, but the marijuana was being used for the anxiety, depression. He was also taking other medications such as Abilify and Wellbutrin. So there was a lot going on there, and wasn't really sure what to expect on that one because of the marijuana use. And what we ended up finding is that we did have pretty much every carrier was willing to offer since the marijuana was prescribed. And they all came in around the table 2 to 4 range. We did have one outlier that came in at table 8, and I still don't understand where they got that, but table 2 to 4 was the norm. There were some carriers that wanted to know the average dosage of the marijuana on a weekly basis, but for the most part, because it was being monitored by a physician, they did not downgrade him due to marijuana use with a mental health disorder. So I use those as examples because, as you can see, when you have 5 declines and 4 standards, that just is proof right there that shopping these cases is key in finding the best carrier for that client situation and under no circumstances are two carriers ever created equally. They all have their own niches, and they change all the time. So just because one carrier was number one on case number one does not mean they were number one on case number two. Some of the carriers that approved case number one were the same ones that declined case number two. So it's a very subjective subject when looking at mental health disorders, and that's why I try to get the whole story, not just the drugs, not just the diagnosis dates. Having a little background can make a very, very big difference in how the underwriters view that. So with all that said, you can call us anytime. You can call me, you can call your sales director, you can email, you can send a carrier pigeon if you'd like. I do like birds, so that's fine. They can come in my office with a little note, and we can shop these cases out. I can get the underwriters on the phone and talk through it. One of my favorite wins of all time was a 24-year-old girl. She had 2 suicide attempts and should have absolutely been a decline. I mean, in writing, on paper, everything about this was a decline. However, I read through her medical records, and this girl, let me tell you, she'd been through it. She'd lost both parents, and she tried to kill herself after each one of them. But 3 years later, she was in college, she was getting married, she was having a baby, she was a nurse. Life was good, compliance with all the treatment was good. She'd done all the talk therapy she was supposed to. And if I would have sent that out as a quick quote, everybody would have declined. Those 2 suicide attempts would have done it. But I got an underwriter on the phone, and we talked through the whole situation, and we got that girl standard. And it just goes to show the situations can make a big difference, and getting a carrier that looks at it holistically and not just statistically can make a world of difference. Keep in mind, we do have health screening questionnaires on our website. You can go out and grab those. I can also send them to you. We have a very generic one that covers everything possible that might come up. And then we also have ailment-specific questionnaires. We've got a NAILBA guide out on our website where we can send you a questionnaire specific to anxiety, depression, PTSD, cardiac, diabetes, whatever you want. There's a whole bunch of them out there, and that digs into everything we need to know about that specific issue. Again, those are on iamsinc.com. You can also call me or the sales director. You can send emails to me directly at andrea@iamsinc.com, or you can send them to prescreen@iamsinc.com. Either one is fine, but I will take those and shop those anonymously. We do not put the client's name on any of those quick quotes, but then we get an idea of tentative offers and who's going to be the most favorable for any given situation. So yeah, anything you have, you give your sales director a call, give me a call, send one of those emails, go out online, get those health questionnaires, and remember that shopping these on the front end and finding out who the best carrier is going to save an immense amount of time on the back end. There is nothing worse than going to one carrier and getting declined when all along we could have, been at somebody who was willing to offer standard or better. And with that, don't forget to follow and like us on Facebook and LinkedIn. And I sure thank you for joining me today. Have a great day.